oversight authority, the first authority under the Ministry of Health to bring whatever good colleagues have mentioned about the health professions. This first authority hopefully will try and spur what you call harmony, like you say, DP, amongst the profession, which has achieved a lot. I want to share my experience having trained at the University of Nairobi with my internship at Kenyatta National Hospital, worked in the government system before I started my own company with 2 staff, Avenue Healthcare, which has now got, over 1,000 staff, and present in over 13 counties. My own personal experience in providing health services and systems. Of course, I have a bent to private sector, so I'm going to talk a little bit about that. But I want to be solution-oriented, and I want to share my experiences in 4 areas that I've seen Kenya Kwanza discuss this amazing discussion on health. So I want to first congratulate the Kenya Kwanza team. Let's give them a round of applause. I've been to many forums, including discussions indoors and boardroom. DP, this is a good one, and I hope you keep it going. And I don't think this is the end. I have heard from Timothy, I've heard from Simon, I've heard from Seth. There are many issues which cannot be really discussed in one day, but I hope it carries on. Let me first say and congratulate the Kenya Kwanza team, because the documents that I've read are fairly balanced between what I consider 60-30-10. I've analyzed your document to be a 60-30-10 document where you're giving a lot of focus on primary healthcare, and that's fantastic. I have witnessed in about 60 or 80,000 patients that we see, 70% of the patients that walk into the doctor's clinic come with preventable illnesses. So if you spend more focus on the preventive and promotive care, which I'm seeing you're giving about a 60%, that's great. I know, David, you were talking about a 30% on the secondary care, and you were putting 10% on the tertiary care. So this pyramid approach, which is almost mirroring bottoms up, and the bottom is literally prevention is better than cure. But it's also cheaper than cure. You agree with me, the people who are in the profession. I have the privilege of also working around Africa and moving in health systems to at least 15 or 18 other countries. I've set up hospitals in 5 other African countries. Kenya is at a very good advantage, DP. To be honest, let's also celebrate our success as Kenyans. Let's not always call everything doom. If you look at when I started, the life expectancy of Kenyans has gone up. The medicines and availability has gone up. The number of doctors and health professions have gone up. Awareness about maternal mortality and infant mortality have gone up. The number of CT scans have gone up. The number of ultrasounds have gone up. So I think we should first give ourselves a round of applause. I mean, for the work that we have done, but there is a journey to go ahead. This country is different from the other neighboring countries because it has 3 strong pillars of healthcare. And in the 100 days, DP, that you have, and all the systems that David and the team are putting together, let's make sure that you are the government of all the 3 systems, because these 3 pillars are important. We have the public sector pillar, which is quite heavily tax funded, and we want to strengthen it. Then we have the private sector pillar, which is also the pride of East and Central Africa. Anybody with a dental problem in Uganda or in Congo, they know if they're in Nairobi, they're safe. In fact, many expats want to move here and settle because they know they'll get good health care. And thanks to the private sector, we've been investing. And the 3rd pillar is the subsidized pillar. Let's not forget the good work that the NGOs and the faith-based organizations are doing. And I really want to give them a round of applause with the church system and all the faith-based organizations across the whole country. We do collaborate a lot. So I think the 3-pillar system must be looked after as we look at all the important areas that we've discussed since morning. I know the first 100 days are important, and I think I also want to stress that health takes time before you see changes. I don't think it's immediate. You know, when you open the expressway and then people just drive. It's like immediate impact. It takes time. Health, you build over time. Health professionals, you build over time. So if you have a long-term plan of 4 or 5 years, you will see health of women, children changing. But you do want to make impact. I would like to suggest 4 areas that this country might find health completely changed in 1 year of your administration. The first one is commodities. And many of us, we know that if the commodities are managed effectively and appropriately, the cost will go down. I support your stakeholder engagement. And I know the petroleum example that David used, most people in healthcare find this competitive overlap in the stakeholder engagement a bit tricky. So how you bring multinationals into that stakeholder and local manufacturers and distributors, I think we'll need to balance it. But I fully agree that where you buy from, how much you buy from, is going to change how much counties are going to be ending up paying. Why should I, in my hospital, when I buy just, say, 5,000 units of antibiotics, pay less than when Kemsa is buying, when they are buying 500,000? Economies of scale should make Kemsa the best buyer of antibiotics. Yet I can buy it cheaper than them from a local manufacturer. Why do the numbers not add up? And if the saving is passed to the county budget can go much longer. So I think there's a lot of work to do in Kemsa. Let's not throw the baby out of the bathwater at the same time. Let's fix where the gaps are. Let's also fix where there may be self-interest. But Kemsa should be able to provide a better price. But DP, let me say one thing. If we decentralize purchasing at 47 counties, one of the worry is where they would buy from. And the market here, unfortunately, when you open a container sometimes, when there's Mutembei and you remove the clothes, at the back, there's a whole load of drugs. Ciproxine, Augmentin. So some people still bring in drugs that are not fit for Kenyans because of the loopholes in the whole system of bringing counterfeit and irregular medicine. Kemsa is happening to give us quality drugs in all the counties. If 47 purchasing units start opening up, the only worry will be, will they start buying poor quality of drugs for the counties? And that may damage the healthcare system, even if we have good doctors and nurses on the ground. So I think commodities is a big one. The second one I want to talk about, which I know you can make an immediate impact, is healthcare financing. And the whole idea, we spoke about risk pooling. And there's been a lot of system, should we have A or B, or should we go for 1 or 2? I think we should have a mixed model of health financing. Let me explain a bit. You know, United States spends $10,000 per capita, per person on health. In Europe, they spend $4,000. We're not yet there. So we also need to be cognizant that our entire budget for the health sector is about $150 per capita. Now, there is so much we can collect from everyone who will be able to pay. Majority of the people are not able to contribute to become an NHIF member. You know, like Timothy said, he doesn't want to use the word indigent. So let's say those who are economically challenged. And the bill to you to make them members might be high. So could we, in financing, again, support both public risk pooling and private risk pooling? And you've mentioned it many times. And if you can contribute to NHIF according to your salary scale, rather than just a fixed 1,700 shillings, and it is pegged on salary, we could be considering it as a levy. In addition to that, you might not want to burden the public health system, and you still can afford the private health system. So my question, honestly, to you is, could we continue letting those who can afford private care use private facilities and leave the public facility for those who would prefer to have a publicly funded system in the beginning until we look at a more national system? So my view is a mixed system is better, When we introduced free primary education, you remember many parents were excited and they went taking their children to school. But many of the people in this room are still paying for private schools for their children. And that was good, because whenever you took your child out from the public system, you left a chair for a child who would not afford education in that school. So in the same solidarity principle, in health financing, I am also fully supporting your idea of splitting NHIF to make it more efficient. You know, we've always said, if you continue doing what you do, you continue getting what you're getting. I'm beginning to hear your structured approach, which is actually a global standard of how social health insurance is managed, where you have a different arm collecting the money, which is the revenue pool. You have a different arm that will be interested in accreditation. Hospitals, clinics, you accredit, and there's a different arm settling claims. When you have the judge and the jury in one state corporate, we get what we get. And this is why we're having inefficiency losses of the $500 million, which I hope should go to $1 billion of risk pooling every year. The third pillar I want to talk about is the pillar of human resources. Kenya is endowed with youthful, English-speaking, smart professionals. We should be taking advantage of these and try to have e-learning systems in place. I realize that the number of people who want to become health workers is far greater than the capacity at KMTC. The admissions that are given, and some of the limitations are infrastructure and faculty. So let's start producing health workers, invest in our faculty, start introducing e-learning, which has been a major way where we are having more health workers coming through, and partner with other institutions to have this CPD and quality of learning that keeps improving. Our partnerships with the global community is pretty good. DP, recently we sent nurses to the UK, which was great. It was a testament. Now, obviously, some of them were told you have to learn English before you come back to UK, and that English was more like, you know, understanding the culture. So there are things that are to be taught in our campuses that need to change. We need to be fit for purpose. Our style and curriculum of yesterday is not fit for tomorrow. We need to understand technology. We need to move from stethoscope to keyboard. We need to have collaboration and patient engagement. I feel we have the best time for human resources for health, like Philippines did many, many years ago, and had a bilateral arrangement. So that's going to be impactful. The fourth one, I think you touched about it. And I think the fourth pillar is digital. And I think you are also so passionate. You make sure you don't miss that point when you talk about it here. I think we should start exporting our telemedical services. Do you know, for many, many years, India had export compensation for pharmaceutical, and we got many packaged medicines coming in. And they've got the trade right, and they're doing it right. They've got that. But recently, they have started introducing digital health and telemedicine to be sold to the rest of the world. In my own office, I have received Apollo Hospital, I've received Manipal Hospital, and you know what they're coming to sell? They're saying, hey, you know what? Your digital films of X-rays, ultrasound, send it to us. We can report it 24 hours. I'm sure many of the health professionals here know what I'm talking about. If they have started doing this, let's beat them to the game. We go to Congo, right? We go to Ethiopia. Let's get the licensing right, and we start selling digital health services, not only for export, but it'll also help us with the electronic medical records that you've been talking about. Once we get the backbone or the architecture of our digital services in place, I think everything else will follow. I'd really celebrate you if you can get that done in the first or the second year. So this is just my own experience that I wanted to share. I hope it's been useful. Good to see you, Stanley. Thanks.
Thank you. One moment, Thaka, sorry.
Yes.
Let me go to healthcare financing.
Yes.
Because that's really the elephant, you know, in terms of where we are today with NHIF, the public deployment of resources, private health insurance, and the whole of that scale. As has been said here, last year we spent in total public, out-of-pocket insurance, close to 550 billion on health. Now, when you say we need a mixed system, you say those who can afford private insurance should continue, should be allowed.
Yes.
And then the people in NHIF should go to public hospitals. Isn't it possible to make it seamless and continuous? Isn't it possible for us, for example, to say, if you are on a private insurance of 80,000 a year,
Yeah.
it's possible for that private provider to cede whatever it is, 20,000
Yes.
of the 80,000
Yes.
to NHIF.
Agreed.
To provide the base.
Yes.
And then the next levels of engagement, as you climb up the ladder of health provision, then the insurance can pick it up from there. So that we do not have two sets. We have one set, but it is continuous, seamless, but structured.
I see.
Don't you think that's...
It's a good suggestion. Let me give you a collaborative proposal. Let's say I'm paying 80,000 for private insurance and I give a levy of 20,000. I want to just use your same argument. Or let's say I call it the fee. And we have, say, 3 million people in private insurance here. And if we divide it by 47 counties, that amount of money that we could get from them as a levy could help 47 counties sponsor the people who are not members of NHIF. So, you know, what I wanted to think of, I don't know the exact numbers, but it's something that I want to speak with David. If we got enough money for the people who can afford. In a county, there are two types of people. There are types of people who are employed and are members of current NHIF, sorted out. But DP, there are many people who are not members of NHIF. To me, that's your priority. A country will be judged by the people, by the system that looks after the vulnerable. How do we get the people who are not members of NHIF to be covered or to get care? And the dual system I was thinking of was, you were saying, let the basic be the standard and then let it be a continuous system. That's one approach. The second approach is, let it be separate systems, both public and private. I also want NHIF members to go to private. Let them choose. In fact, let them vote with their feet. That way the public sector will become better. But let the private sector pay a certain fee that will help many of the people who are not members of NHIF to get a fund. 47 counties. I'm trying to figure that out. And so we have more people who are covered and are catered for into the system. And those who are not members will end up going for primary health care anyway, which is tax-funded system. If you make our clinics fantastic, like you said, dispensaries, so there's no lack of doctors, where you are looking at health centers, believe me, you will put pressure on the private sector. Because as government pulls up its socks, we have to pull up our socks. And the whole system will go up. So,
Okay, maybe so that I can give it to David. I would not, Thaka, I would not go for the people who are paying private. I would not want them to pay a fee to NHIF
Okay.
to take care of indigents. No.